All right, week 9, alterations, cardiac function, cardiomyopathies, endocardial things, pericardial things. Come on, there we go. So the heart is divided up into 3 sections. We have here the endocardium, which is very thin. We have here the myocardium, which is the big, thick, muscular layer. And then we have the shell, which is the pericardium. So in general, with endocardial diseases, including diseases that affect the valves themselves, the etiology of these come from inflammation and scarring over time, calcification, or they can come from congenital malformations. When we have damage to the endocardium, especially with the valves, we can have some very significant alterations in hemodynamics, which can also result in an increase in myocardial workload. So people may have been able to, or may have been told early on the importance of making sure that any sore throat, especially a child has, is quickly identified to either be or not be strep throat. That's because strep throat has the potential of leading to rheumatic heart disease. So rheumatic heart disease is generally a valvular issue that stems from an acute inflammatory disease following infection with group A beta hemolytic streptococci infection. So here, what happens, the reason why this is a problem is the bacteria that infect the throat, that create strep throat, lead to the formation of antibodies. Those antibodies, while they're great at taking on the streptococci, they also can't differentiate between streptococci and the connective tissue in the joints, in the heart, and in the skin. This normally occurs or mainly occurs in children, though adults can also develop it. They'll present with fever, sore throat, your typical strep throat symptoms, but then present further on, when you really want to be scared, with joint inflammation, involuntary movements, and as we can see here, a distinctive truncal, being the trunk of the body, rash. So when you see this kind of a truncal rash, or have joint pain or involuntary movements, ER right away. We can also experience infective endocarditis. This is going to be the invasion or colonization of the endocardial structures by microorganisms, resulting in inflammation and vegetations. So strep and staph or coccus are going to be our most common etiologies, with strep being more common than staph. And the vegetations that we're referring to here are going to develop up on the valves. And what a vegetation is it's this accumulation of microbes and the immune system's response to those microbes. It kind of develops this thick, hard to penetrate blob that is constantly emitting more chemicals to promote inflammation, and can be very destructive to the valves. We can develop some very significant valvular issues that I think you guys learned about this past week, leading to very significant hemodynamic alterations. Acute infective endocarditis usually does not respond well, and IV drug users are very susceptible because a lot of the etiological microbes that can cause this live on our skin. And so when IV drug users don't prep the skin well, and that's not normally what they're thinking about, with alcohol or chlorhexidine, before injecting their skin with a needle, they are introducing the microbes that live on our skin in a healthy state into an environment, our blood, where they're not meant to be and can cause very significant damage. So with the myocardium, the diseases that affect the myocardium can be kind of divided into 2 different classes. We can have myocarditis and cardiomyopathies. With myocarditis, this is an inflammatory disorder where we can end up with necrosis, and general degeneration of myocytes. This is a shorter development of a disease process compared to cardiomyopathies. Myocarditis can develop over weeks to months, which is important to remember. Um, and cardiomyopathies usually develop over years, and there are going to be few symptoms experienced until heart failure develops. And cardiomyopathy is not inflammatory. Myocarditis can occur from several options. Viral etiology is the most common. Um, I don't remember which viruses are. I think it was some random, long, complicated name for a virus. Um, but we can also have autoimmune mediated responses that lead to myocarditis, as well as drugs and chemical agents leading to myocarditis. The way it works is we end up having some form of an immune response, regardless of whichever etiology it was, the leukocyte infiltration, and we then start to have muscle tissue breakdown. So the myocytes themselves start to experience destruction and death, necrosis. This leads to a flabby left ventricle, leading to, of course, same with heart failure, left ventricular dysfunction. Eventually, the dilation of all four chambers can result, which, of course, is horrible towards actually producing any cardiac output. So the difference between myocarditis, okay, myocarditis and cardiomyopathies. So with myocarditis, as we see here, and it kind of extends to the atrias eventually, per the dilation of all four chambers, we have inflammation of the myocytes, of the myocardium. With cardiomyopathies, these are two of the three that we end up having. There are changes to the myocardium itself, not from inflammation, but from other processes that we'll get to here in a second. With myocarditis, we can have clinical manifestations of general inflammation, both of the heart itself and systemically. So we may see ESR rates going up, fatigue, dyspnea on exertion because the body's not going to be able to sustain cardiac output with myocarditis, and so any form of exertion is going to result in more pronounced and obvious dyspnea. And then because the heart's not working well and may starve itself of some oxygen, we also may experience some dysrhythmias. Eventually, it can also lead to dilated cardiomyopathy and heart failure. So cardiomyopathies, this is where the bulk of our text is today. They can be divided up into primary or secondary classifications. So primary being that they are of an unknown cause, just suddenly someone has it, we don't know why, or secondary being from a known cause. Another form of classification that we can have is dividing them up into whether they are, with this being a normal heart, a dilated cardiomyopathy compared to that normal heart, hypertrophic cardiomyopathy, which, as we see here, this is the normal muscle of the heart, and then this is the much more hypertrophied ventricle of a hypertrophic cardiomyopathy. We can also have a restrictive cardiomyopathy, where it looks similar to the hypertrophic, but the difference is that right here we have this ring of fibrosis that makes it difficult for the ventricles to actually expand and contract. So with dilated cardiomyopathies, the etiologies include alcohol toxicity, with alcohol abuse, overuse of alcohol. We're looking at having hypertension. Alcohol overuse can cause hypertension, which itself can lead to heart failure, cardiomyopathies, and dilated forms. As well as, for some reason, as said in the textbook, alcohol itself can impact the heart. I don't remember, it didn't really explain why or how, but that was one of the reasons. Pregnancy, don't know why that is. Post-viral myocarditis, so you have myocarditis, and it's affecting the myocytes. Eventually, if it's not treated properly, it can lead to this dilated cardiomyopathy. people can also simply have a genetic abnormality that either leads or where they're born with it. It could be congenital, or it could be that they are prone to it and develop it over time. So the pathogenesis is that we have dilation of one or both ventricles. For one of these reasons, there could be more etiologies than just these. That leads then to heart failure. And this is generally a slow progression. So, for example, with hypertension, hypertension can be an etiology that leads to dilated cardiomyopathy. If you have perpetual, constant high levels of blood pressure, high hypertension, eventually the ventricles are going to start to give out, and this can be a form of heart failure. And it's going to be, since we have reduced ejection fraction, they're referring to systolic dysfunction or heart failure with reduced ejection fraction, because when it's dilated, we're talking about a ventricle that's going to have a hard time pumping out fluid, pumping out blood. It's not going to have any problem fully expanding to accommodate as much blood as it can hold. In fact, it'll probably hold more blood than it would in a normal healthy heart, but it's going to be weak on being able to contract because of the death of all of those and the uncoordination from just simply having not enough muscle of the myocytes. And this is a really good example of what this dilated cardiomyopathy would look like compared to a normal heart. So the normal heart here, we've got all of this nice thick tissue around the left ventricle, whereas over here, we kind of have the same volume and size perhaps of the myocytes, but they're spread out over such a massive area, and they're weakened because they don't have as many myocytes to work together in coordination. A strong, healthy muscle needs to be large enough to complete its work. And if there's not enough to work together, as you know there would be here, then instead we're going to have all of these performing a weak half effort of trying to contract. So with the dilated cardiomyopathy, this is going to present manifestations. So the myocytes are going to be both hypertrophied and atrophied. They're going to be hypertrophied because originally they're going to try to accommodate whatever it is that's leading to them needing to work harder. But eventually they're going to die off or become so weak that they just atrophy instead. There may be some mild fibrosis as well, because with any form of inflammation, though this is not an inflammatory issue, but the cells are going to be stressed, there may be some mild inflammation leading to some mild fibrosis. And because we're talking about an inability to pump out much in cardiac output, we're going to have heart failure symptoms. So our next cardiomyopathy is going to be hypertrophic cardiomyopathy. This primarily is a genetic abnormality, being autosomal dominant. So that means that it's a dominant trait. If there's a greater chance that your kids are going to have it. But it can also come from having hypertension too long. Perpetual hypertension is a potential that was in the book. The general pathogenesis is that we have a protein mutation of cytoskeletal proteins, some sort of mutation of those. So they end up becoming more thickened, hyperkinetic, meaning that they are more likely to contract and act quickly, adding to the stress and the workload that they experience in the ventricular muscle. So the progression kind of is a little bit variable. We may have a very rapid progression, or we may have a very slow progression, or somewhere on that spectrum. But typically they are a slow progressing disease, and people may actually have a completely normal life expectancy. So with a normal heart, we have all of this nice, thick, reasonably thick, but still accommodating left ventricle with plenty of space on the inside to fill. With hypertrophic cardiomyopathy, we have a bit thicker exterior wall, but this intraventricular wall is just massive. It has absolutely swollen, whether it be from stress or from this genetic abnormality. And so now we have very little space to accommodate any blood. And these hearts are also hyperactive, hyperkinetic, leading to further hypertension, hypertrophying of the myocytes, and also leading to a decreased time period for the left ventricle to fill. We can also have hypertrophic cardiomyopathy with an obstruction. So what we mean by that is he's still here. We have, this looks a bit thicker. I'm not sure how often it really is thicker with this form of hypertrophic cardiomyopathy. But in the intraventricular space, we have this kind of jutting out of part of the septum from hypertrophying, leading to a difficulty in pushing blood past it into the aorta. So that's only going to make the left ventricle even more stressed and leading to greater hypertrophying and eventually death. So the septum is most affected in 20% of cases, leading to aortic outflow obstruction, which is right here. So the manifestations for hypertrophic cardiomyopathy is going to be a slow change of function, over years. A lot of people may be completely asymptomatic and not even recognize they have it. But when they do start having signs and symptoms, it's going to be dyspnea and angina as the typical presenting symptoms. And we're going to have, in addition to that, as it progresses, heart failure symptoms, specifically diastolic. Because remember, when we talk about systolic versus diastolic dysfunction, this is going to be our systolic dysfunction. I don't really know where I was just now. My cat took a giant dump and that stank to high heaven. I had to do something about that. I think I was talking about how the differences between systolic dysfunction and diastolic dysfunction. Yeah, okay. So this is systolic dysfunction, right? Because this is so large but weak, we can have plenty of fluid accumulation inside of it, but then it's going to be difficult to actually eject out. Whereas with hypertrophic cardiomyopathy, either direction, it's going to be difficult for all of this to relax because it is hyperkinetic, leading to an ability to fill up all the way, but there's not going to be much that we can pump out because it's not relaxing. Oh wait, no, I may mix it up. It can pump out everything just fine, but it's not going to be able to open up completely and relax to the point where it can fill enough to actually produce enough cardiac output. So patients may also experience sudden cardiac arrest or from dysrhythmias, because we're looking at hyperkinetic activity with hypertrophic cardiomyopathies. And so with that comes the potential that they can enter into a really powerful dysrhythmia, which can also come from the fact that they're not able to provide enough oxygen to itself with enough of a work demand or a workload and oxygen demand. With hypertrophic cardiomyopathies, we want to avoid inotropic drugs. So we're talking about things like digoxin or dopamine here. These are things that are going to promote an even stronger contraction, and we don't want that. We want to, because what's that going to do? That's going to simply increase our heart's workload, making it even more, requiring even more oxygen and stressing it out even further, but it's not going to be able to meet that demand. So that's that's going to make things worse. Whereas using things like beta blockers and calcium channel blockers, these are going to slow the heart down, trying to keep that hyperkinetic activity to as much of a minimum as we can, allowing the heart to fill up with blood, and allowing the coronary vessels to get enough blood flow to provide oxygen for the myocytes. Restrictive cardiomyopathies are the rarest type of cardiomyopathies. The most common etiology for these is going to be amyloidosis. In case no one's figured out what amyloidosis is, this is sort of like a buildup and replacement of normal proteins with an abnormal form. And so what happens there is the myocytes of the heart in the myocardium slowly become replaced with this not very effective protein. It's not specific for cardiac muscle, which ends up not being able to contract properly and pump out blood. It can also be genetic, or through radiation, or some form of toxin that promotes fibrosis. The biggest thing about restrictive cardiomyopathy is the development of rigid fibrosis. So we develop this rigid fibrotic ventricle, which leads to, similarly to hypertrophic cardiomyopathy, an impaired diastolic filling. So this is going to be a diastolic dysfunction, a heart failure with preserved ejection fraction. This leads to a decrease in cardiac output and left-sided heart failure. Yes, thank you. So with the restrictive cardiomyopathy, the heart can actually look very similar to a normal heart with one specific exception, is that we have right through here, all of this is fibrotic buildup that leads to an inability of the left ventricle to fully expand. They can fully contract to get, potentially, that might actually be something that it has difficulty with as well over time. But the biggest problem is not its ability to contract, but its ability to expand and accept as much blood as a normal, healthy heart is able to. So clinical manifestations, similar, if not exactly the same, as heart failure, is going to be exercise intolerance, dyspnea, and weakness. All right, so now we're going to move on to the pericardium. So pericardial diseases can come from multiple etiologies as well, like systemic infection, trauma, metabolic disease, cancer, or neoplasia. So the first one we're going to talk about is pericardial effusion, which is the accumulation of fluid in the pericardial sac. So this is problematic because the pericardial sac is rigid. The pericardial sac is actually sort of a safeguard in some ways for the heart. It prevents the heart from over-expanding to the point where it damages the myocytes or endocardium. So again, the pericardial sac does not expand, it is rigid. When we start to build up fluid in here, that can get in the way of forming or maintaining proper hemodynamics. The most common form of etiology on this is generalized fluid overload. So a patient experiencing high levels of fluid overload from heart failure can experience this. It can also be iatrogenic, being that medical professionals have caused it. It can be infection related or from a general inflammatory disease, both of which causes fluid to accumulate as part of the inflammatory process, or it can come from a neoplasia. Neoplasia, I don't know how you spell it or say it. All right, so now pericarditis is going to be inflammation of the actual pericardium, that rigid sac around the heart. This can come from also multiple causes, and it becomes really problematic when it becomes a chronic issue. So this may have healed from an acute form and formed a chronic pericardial dysfunction due to fibrosis and calcification. And I believe this is the one that leads to sort of a sound of, I want to say like kind of like not Rice Krispies sounds, but a rubbing. I forgot what it was that's called, but a rubbing of tissues because the inflamed pericardium is becoming thicker. It's rubbing up potentially against the myocardium itself and could become very painful for the patients. Cardiac tamponade is a much more serious issue. And cardiac tamponade is actually a more progressive form of pericardial effusion. The difference is, with cardiac tamponade, and this is the important distinction, cardiac tamponade has reached a fluid level or accumulation that actually impedes on the heart's ability to fully expand. So with cardiac tamponade, there's, as it is with pericardial effusion, a large or sudden accumulation Would you write? Thank you. A large or sudden accumulation of fluid to the point where external compression of the heart chambers is affected. So we fill up so much fluid here that eventually, since the sac is rigid, it starts to compress the heart. And we're not going to be able to have the heart fully expand to accept blood. It's going to act kind of like a restrictive or hypertrophic cardiomyopathy, where the heart can't expand all the way, like a diastolic dysfunction heart failure. So there are a number of ways this can happen. We can have penetrating or blunt trauma to the chest. It can be iatrogenic from another procedure. There can be metastasis from breast cancer or lung cancer. We can have a ruptured aortic aneurysm. It can result from acute pericarditis, and then we could also have it result from cardiac infections. A lot of the same things that can happen from for a pericardial effusion can lead to cardiac tamponade as well. And for this, it's important that we find a way to quickly get all that fluid out of the pericardium. This is like an emergent issue because people can go into cardiac arrest from this. All right, let's see. So myocarditis is an inflammatory disorder characterized by scattered necrotic and dead heart muscle tissue or cells that is most commonly associated with viral infections. And myocarditis is left ventricular dysfunction and dilation of the heart chambers with reduced contractility. I'm trying to make sure that we have nothing else on here to go through. No, I think that's about it.